So very good evening, everybody. I would like to thank the organizers of the Pediatric Diabetes Update for inviting me, and thank you, chairpersons, for the introduction. The topic for this talk is neonatal diabetes mellitus. We'll be covering the definition, types, etiology, clinical presentation. Then I'll be discussing a case scenario, and then going on to diagnosis and management. So neonatal diabetes is also known as monogenic diabetes of infancy, and it is typically defined as onset of persistent hyperglycemia within the first 6 months of life. However, this condition may present up to 12 months of age. And nearly all the cases of diabetes before 6 months of age are neonatal diabetes, that is, they are monogenic in etiology. And a small proportion of cases between 6 to 12 months, onset between 6 to 12 months, are also of monogenic etiology. The incidence is 1 in 90,000 to 1 in 160,000 live births. There were some turning points in the history of neonatal diabetes mellitus, and this condition is a fairly a new disorder in the sense that it was first described in 1995 only, and then between 95 and 2006, many of the genetic defects were identified. The first mutation was in PDX1 gene, which causes pancreatic agenesis and thus leads to a permanent kind of neonatal diabetes. And this one was identified in 1997. Subsequently, in 2004 and 2006, the most important mutations, that is those in the ATP-sensitive potassium channels, KCNJ11 gene and ABCC8 gene, these mutations were identified. And we all know that the discovery of these mutations has actually led to a dramatic change in the way we manage babies with neonatal diabetes. And now mutations in 22 different genes are already been identified. So coming to etiology, so genetic mutation can be identified in about 80% of children with neonatal diabetes. And activating mutations, that is gain of function mutations in KCNJ11 and ABCC8 genes. These two genes, they account for about 40% of all neonatal diabetes mellitus cases. In this figure, what is shown is that in non-consanguineous marriages, KCNJ11 gene accounts for a majority of cases of neonatal diabetes, up to around 30%. And ABCC8 gene is the second most important one, accounting for another 15% or so of cases. And then the third one is 6q24 abnormalities, which we all know causes transient neonatal diabetes. And fourth most common is insulin gene abnormalities. In contrast, if the baby is born out of a consanguineous marriage, then IF2AK3, that is, this is the gene mutation which causes Wolcott-Rallison syndrome. This assumes a more important role, and it is accounting for nearly 25% of all cases. So coming to pathogenesis, as we all know, this is monogenic diabetes, and three important mechanisms have been described. So first is that the gene defect can cause abnormality in the development of pancreas. That is, either the pancreas, the whole of the pancreas can be absent, or islets can be absent. So this is seen in conditions like PDX1 defect, which is a transcription factor, and PTF1A mutation. In this PTF1A mutation, there is defect in pancreas development as well as cerebellar neurogenesis. The second mechanism is decreased beta cell mass secondary to increased apoptosis or destruction. And the most important example is heterozygous defects in insulin gene. So this causes synthesis of misfolded pre-pro or proinsulin that is retained in the endoplasmic reticulum and results in apoptosis of the beta cells. So here, even though the defect is in the insulin gene, the problem ultimately is that the beta cell mass becomes very low. And the third defect is beta cell dysfunction that limits insulin secretion. So here the most important conditions are the gain of function mutations in the potassium channels, that is KCNJ11 and ABCC8 genes, and homozygous insulin defect that also causes beta cell dysfunction with limitation of insulin secretion. This figure shows the pancreatic beta cell, and basically what we can see here is the ATP sensitive potassium channel with its two subunits, the sulfonylurea receptor 1 and the potassium inward rectifying 6.2 subunits. So this has a central role in um, insulin secretion. How? Basically, during the resting stage, this potassium channel is allowing the potassium to escape out of the cell. But when there is glucose metabolism, when glucose is high, as in the postprandial state, glucose comes in and glucose metabolism leads to rise in ATP. And this causes this potassium channel to close, leading to depolarization. Depolarization leads to opening of this voltage gated calcium channel. Calcium comes in, leading to exocytosis of insulin. So if there is gain of function mutation of this channel, what's going to happen is that potassium will continue to escape out and the cell will not depolarize and insulin will not release, leading to neonatal diabetes. In the opposite condition of loss of function, there is going to be insulin exocytosis even in the absence of glucose metabolism, so leading to hyperinsulinemia. Okay. So when to suspect neonatal diabetes? We know that hyperglycemia may occur in infants due to a variety of causes, right? Especially common in sick preterm and low birth weight infants due to sepsis, increased counter-regulatory hormones, parenteral glucose, and medications such as steroids and beta agonists. This is especially seen in the first few days of life and resolves within few days of onset. And it's more common in early preterm infants, that is less than 32 weeks of gestation. So when you see hyperglycemia without these known risk factors, or even in the presence of these risk factors, if it is persistent beyond 3 to 5 days and it is insulin responsive, so you should think of working up for neonatal diabetes. Another clue is that most infants with neonatal diabetes have IUGR because insulin is important for fetal growth. Up to 50% of affected infants actually present with diabetic ketoacidosis, while the rest are diagnosed due to incidental detection of hyperglycemia or with features such as irritability, polyuria, and failure to thrive. Coming to clinical phenotypes of neonatal diabetes, there are three phenotypes. First is permanent, that is, the diabetes does not remit. It is the commonest type of neonatal diabetes. And most commonly implicated are activating heterozygous mutations in ABCC8 and KCNJ11. The second one is transient. And this is actually a misnomer because one should always remember that infants who have transient diabetes, they have 50% or higher chance of relapse later on in adolescence or adulthood. So it's not truly transient and the vigilance should be maintained for relapse. So hyperglycemia resolves typically by few weeks to months, and 70% of these are caused by mutations in 6q24. Then the syndromic type of neonatal diabetes, in which diabetes is part of a constellation of abnormalities. And the most common here is IF2AK3 mutations. So talking a little bit more about transient neonatal diabetes, it typically presents within the first few days to weeks. And intrauterine growth restriction is common. Macroglossia and umbilical hernia may be present in a few babies, and it resolves within few weeks to months. About 50% cases relapse in adolescence or young adulthood. Insulin is typically used in infants, but when diabetes recurs in older age in adolescence or adulthood, then it is managed as type 2 diabetes with sulfonylureas. And recently, there has been a case report in which successful use of sulfonylurea has been mentioned in babies with transient neonatal diabetes as well. What are the molecular defects here? So as I mentioned earlier, the most common defects are in about 70% of the babies. It is overexpression of the 6q24 chromosomal region. So in this chromosomal region, there are basically two genes, that is Plagal1, also known as ZAC, and HYMI. These two genes are interesting in that typically only the paternal allele is expressed while the maternal allele is imprinted. Imprinted means that it is methylated and it is not expressed. So if there is duplication of the paternal allele or disomy, uniparental disomy, or abnormal methylation of the maternal allele, so that even the maternal allele is expressed. So in all three conditions, there'll be overexpression of this region. So this presents as transient neonatal diabetes. Another interesting defect in this same region is that there can be homozygous mutations in ZFP57. This is a zinc finger protein, and it codes for a transcription factor which is required for methylation of several genes. So again, if there are defects in this gene, so methylation of the maternal allele will not occur, and transient neonatal diabetes can occur. So in 25% of babies with transient neonatal diabetes, you find mutations in KCNJ11 or ABCC8 genes. And the others are insulin gene mutations. So remember that insulin gene mutation as well as KCNJ11 and ABCC8 gene, they can cause both transient and permanent forms of neonatal diabetes. Then HNF1 beta mutations and SLC2A2 mutations, that is the gene defect which is responsible for Fanconi-Bickel syndrome. We'll talk a little bit more about it later. Okay. So coming to permanent neonatal diabetes, so as the name suggests, obviously it requires lifelong therapy. The median age at presentation here is somewhat later than transient neonatal diabetes. It presents at around 3 to 4 weeks. And mean birth weight of most of the affected infants is between 10th to 25th centile. Approximately 50 to 60% of cases of permanent neonatal diabetes mellitus are caused by defects in the potassium channel genes, and thus these are amenable to sulfonylurea therapy. The rest are caused by defects in other genes like insulin, which is responsible for around 20% of permanent neonatal diabetes, and others like glucokinase, GATA6, GATA4, and PDX1 gene defect. And all of these will require permanent insulin treatment. One interesting entity that we should all be aware of is DEND. What is DEND? DEND stands for developmental delay, epilepsy, and neonatal diabetes. So it happens because the ATP sensitive potassium channels, they are expressed in the brain also. And a few patients with KCNJ11 gene defect, and also less commonly those with ABCC8 gene mutations, may have a wide range of neurocognitive disabilities such as decreased reasoning ability, reading disturbances, sleep disturbance, ADHD, etc. And in severe cases, they present with the full-blown DEND syndrome. So, in fact, with sulfonylurea treatment and with early sulfonylurea treatment, there are now several papers which have shown that the neurological abnormalities can also be controlled. And the most common mutation in KCNJ11, which has been shown to be associated with DEND syndrome, is this one. So if you go ahead and get a mutation testing in your baby, in your patient, and you find this particular mutation, always be aware that this child is at risk of neurocognitive disabilities, and you should be vigilant for that. And also, sulfonylurea treatment has to be given at a preferably at a higher dose because it will be beneficial for this baby. Okay. So next is coming to syndromic neonatal diabetes. So as I mentioned earlier, the most common type is Walcott-Rallison syndrome, and it is especially common in consanguineous, in babies born out of consanguineous marriages. So this syndrome is characterized by several features, the most important being skeletal dysplasia, growth retardation, episodic liver failure, renal dysfunction, pancreatic exocrine insufficiency, neutropenia with recurrent infections, hypothyroidism, and mental retardation. This is the gene, and the course is that the onset is around 3 months, and it has a poor prognosis. And in fact, we had managed 2 cases, both of which did not have a favorable outcome, and the problem was episodic liver failure. So, and failure to thrive because of pancreatic exocrine insufficiency and recurrent infections. Okay, coming to the next one, which is Fanconi-Bickel syndrome. So, as many of you might be aware, syndrome is typically characterized by hepatomegaly and generalized proximal renal tubular dysfunction, so proximal RTA, and rickets. So, in fact, you have families in which one child may have predominantly renal or hepatic complaints, and the other baby may present as neonatal diabetes, both with the same mutation. So, the defect here is mutation in solute carrier family 2A2, SLC2A2 mutation, which encodes the GLUT2. And the presentation is variable, and this may be transient. The third one is IPEX syndrome. IPEX stands for immunodysregulation, polyendocrinopathy, enteropathy, X-linked. Here the defect is in FOXP3 gene, and this can present at birth. Okay, so I'll be sharing a brief case. We had a 2-month-old girl child from Ranchi who came to us. She was born at term to a non-consanguineous couple and was first in birth order. There was an antenatal history of oligohydramnios with intrauterine growth retardation. There was no adverse perinatal event. She cried immediately at birth, and birth weight was low, 2.05 kilogram. At 1 month of age, this baby developed fever, fast breathing, and increased urine output. And on investigation at Ranchi, she was found to have a blood sugar of 664 milligram per DL, urine sugar of 4 plus, urine ketone 1 plus, blood gas showed mild acidosis, and blood culture showed Klebsiella. She was managed as diabetic ketoacidosis. A diagnosis of neonatal diabetes was made, and she was started on insulin and was advised exclusive breastfeeding. However, as we all know, it's not easy to manage these babies on insulin, and there are episodes of hyper and hypoglycemia. So she came to us with all these issues. So here she was admitted at 2 months of age. Her weight was found to be 3.1 kilo at 2 months, which is like a slight failure to thrive is there. There was no dysmorphism. HbA1c was done to 7.8%, although the utility of HbA1c at this age is not much, because we know that the fetal hemoglobin is also there at this age. Ultrasound abdomen showed normal pancreas. Thyroid function was normal. She was managed on NPH and regular insulin with dilution, and then DNA was sent for genetic diagnosis. So we typically send our DNAs either to Exeter, which was where we used to send all the patient samples because it was being done free of cost as part of a research project. Recently, for the past few years, in fact, we have also been sending our DNAs to MDRF Chennai, where again they have research projects which are funded by ICMR and other agencies. So it's a good choice to send to MDRF as well. So in this baby, a heterozygous KCNJ11 missense mutation was found. The parents didn't have any mutation. The baby was started on sulfonylurea, that is glibenclamide, and dose was increased to a maximum of 1 mg per kg per day as per protocol, and we were able to stop the insulin on day 7. So this is interesting. This is the baby's CGM record on insulin, and as we can see, she was euglycemic only for 12% of the time, and most of the time she was in hypo or hyperglycemia. And this slide shows her CGM record after she was successfully transitioned to sulfonylurea. So that's the beauty, because it mimics the natural insulin release by the pancreatic beta cells. So there is hardly any hypo or hyperglycemia. Okay, so coming to the last part of the presentation, that is diagnosis and management. So when you're working up a baby with neonatal diabetes, you need to take family history of consanguinity, whether there is gestational diabetes, whether there is early onset type 2 diabetes, because these may actually reflect milder forms or heterozygous form of some homozygous defect that can lead to neonatal diabetes. So evaluation of first degree relatives by OGTT. Associated clinical features should be looked at, like low birth weight, dysmorphism, umbilical hernia, macroglossia, hypothyroidism, because some of the syndromic kind of neonatal diabetes have these. And as I already told you, in transient neonatal diabetes, umbilical hernia and macroglossia are common. Skeletal dysplasia, liver disease, eczema, again, they can tell you about some of the syndromic forms of neonatal diabetes. Ultrasonography of abdomen can be done to look for pancreatic agenesis and renal abnormalities, and brain, well, plus minus. I would not really do this. Okay. Then a workup. So if the infant is aged between 6 to 12 months, then you can test for autoantibodies first and go for genetic testing only if the autoantibodies are negative. This is because the um, percentage of babies with the monogenic kind of diabetes or neonatal diabetes in this age group is much lower. In infants aged less than 6 months, the strategy can be that you can test for 6 to 24 abnormalities in cases where the diabetes has already remitted at the time of referral, or if the baby was born with significant low birth weight and is between 3 to 6 months old. For permanent neonatal diabetes, when you're thinking of permanent neonatal diabetes, then sequencing of KCNJ11 and ABCC8 is done first, followed by insulin, and then others guided by additional clinical or syndromic features. In consanguineous families, IF2AK3 is also done. Clinical presentation can give really important clues to the underlying genetic defect. So if the baby has presented in DKA, then more chances are that this baby has mutations of KCNJ11 or ABCC8, and maybe in insulin gene mutations. And typically DKA is not seen in babies with transient neonatal diabetes due to overexpression of 6 to 24. Okay, malabsorptive diarrhea, that is exocrine pancreatic insufficiency, is associated with the defects which are listed here: GATA6, IF2AK3, PTF1A, PDX1, and RFX6. Extrapancreatic findings. So polycystic kidney disease is associated with HNF1 beta defect. Neurological abnormalities, developmental delay. So KCNJ11 is most commonly implicated. Others are NeuroD1 and PTF1A. Immune dysregulation, we already discussed this one. It is associated with IPEX, hypothyroidism with GLIS3, deafness with Wolfram syndrome and SLC19A2, and skeletal abnormalities associated with Woolcott-Rallison, hepatic dysfunction with Woolcott-Rallison, and Fanconi beetle. Okay, but interestingly, now with more and more labs going in for next generation sequencing, the algorithm of workup has actually changed, and this may be for the better. And here what you would do is that any infant who presents with neonatal diabetes, you can do early non-selective next generation sequencing for all the known NDM genes. And then your genetic diagnosis would predict the course of the baby and the development of other clinical features. And then the management and vigilance for evolution of new features would be guided by the genetic diagnosis. So for example, if you do the test in a baby and you find IF2AK3 mutation, you will know that, okay, this baby is more likely to develop skeletal features. Remember that skeletal dysplasia is not very evident at birth. In most babies, the manifestation would actually come up after 1 year of age of skeletal development abnormalities or growth retardation or liver involvement. So these features appear later. Similarly, again, if you have done a test and you find ZFP57 mutation, then that is like, okay, this baby is likely to have a transient neonatal diabetes. Okay, coming to management. So diabetic ketoacidosis is managed as per usual protocol. And later on, when we are managing the baby, the ambulatory management, then the insulin dose requirement is very, very low. We know that it is usually only 0.3 to 0.7 units per kg per day, and such small doses, so if the baby is 2 or 2.5 kilos, then the dose requirement for the entire day may be less than 1 unit. And this has to be given in divided doses, so it's difficult. It is better to use insulin pump wherever feasible, and but again, there are problems with that in babies with very low birth weight, with subcutaneous fat being limited. It's not easy to uh, deliver insulin by pump, and cost is also prohibitive. So this is not possible many times. So if using injections, we may need to dilute the insulin. And for diluting insulin, although commercial diluent is available, but it's not easily available in India, so you can dilute with saline. Then avoiding hypoglycemia is an important challenge, and therefore our goals should be set in accordance with the kind of regime that we are using, whether pump or MDI, and also the monitoring strategy that we are using, whether CGM or finger stick. So parents should be given very simple, clear instructions regarding the dose of insulin to be given. They should be taught how to dilute it properly, how to monitor sugar at home, how to manage hypo and hyperglycemia, and checking the ketones and all when baby is sick. And close follow-up needs to be maintained. And generally, it is better to avoid a trial of sulfonylurea without a molecular diagnosis. And now with MDRF being here and Exeter being free, of course. So diagnosis is not really too much of a difficulty. So it's better to wait for the genetic diagnosis before going ahead with trial of sulfonylurea. Okay, coming to sulfonylureas, if we are able to identify and activating ATP sensitive potassium channel mutation, then that enables switching from insulin injection to oral sulfonylureas in more than 90%. So remember, it's not 100%. Few mutations are known to be relatively refractory to treatment to sulfonylureas, and also if the patient has had diabetes for a long period before transition is attempted, then the transition may not be totally successful. However, the dose of insulin usually goes down. So in any case, um, in our experience till now, fortunately, all the babies with this mutation, we were able to transition successfully. And the sulfonylurea with most experience is glibenclamide, but you could also use other medicines like glyburide or glipizide, and they are started at 0.1 mg per kg per dose in 2 to 3 divided doses and titrated upwards up to 1 mg per kg per day. Although now there are few case reports in which even a higher dose has been required in few babies, and especially as I mentioned earlier, in those with DEND, that is developmental delay, neurological abnormalities, epilepsy, it may be better to give a higher dose, and this higher dose may help with the neurological issues. So people have used higher doses up to 1.5 to even 2 mg per kg per day, and thankfully, hypoglycemia is not much of a problem. Okay, so risk of severe hypos as well as hyperglycemia is very, very low. And yes, it has beneficial effect on dent. And adverse effects are skin allergy, diarrhea, anemia, leukopenia. All of these are rare. And this diagram basically shows how sulfonylureas act. So this is the potassium channel, and these are the subunits, the potassium inward rectifying channel and the sulfonylurea receptor. And on this sulfonylurea receptor, it is inhibited by sulfonylureas. So if it is inhibited, then it won't let potassium pass and it will cause depolarization and hence insulin exocytosis. Okay, coming to the last part of this presentation, that is Indian experience with neonatal diabetes. Starting with our own experience at AIMS Delhi, we've published a few papers, and one was a case series in which we described 11 babies, of which 8 had permanent neonatal diabetes. And the mean birth weight was 2.4 kilos, and mutations were identified in 7 babies, of which potassium ATP channel mutations were present in 4, more in KCNG11, only 1 in ABCC8, and these were all switched over to oral sulfonylureas. And besides this, 2 infants had mutations in INS and 1 in ZFP57, which causes transient neonatal diabetes. Subsequently, we've also managed infants with Wolcott-Rallison syndrome, 1 infant with Fanconi-Bickel syndrome with transient neonatal diabetes, and 2 with transient neonatal diabetes due to INS gene mutations, and also 2 with SLC19A2. What is SLC19A2 mutation? This mutation is responsible for thiamine responsive megaloblastic anemia. So these babies typically do not present very early. So our cases had presented at the age of around 8 to 9 months, and as we know, this is a very interesting syndrome in which there is anemia, there is deafness, and there is diabetes, and this is thiamine responsive. So the anemia improves, and even the insulin dose goes down with thiamine. Okay, so the other cases that have been reported from India are one from Chennai, case series from Chennai, in which 10 babies were described, out of which 9 had permanent neonatal diabetes. Then another one from Cochin by Lakshmanan et al., in which 15 babies with neonatal diabetes have been reported, of which 9 had permanent and 6 had transient neonatal diabetes. And then from Mumbai, there is a case series of 6 cases. And Janavi et al. From Chennai, this is the MDRF group. So they published in 2013 a case series of 33 babies, of which this is somewhat different from the others in that they have found more mutations in ABCC8 gene. So whereas in literature, as well as in our series from northern part of India, KCNJ11 mutation was more common, but in this ABCC8 mutation was more common. Okay. So the key takeaways from this talk are that diabetes, which presents before 6 months of age, is most often monogenic and not type 1 diabetes. IUGR is common, and nearly half of these babies present with diabetic ketoacidosis. So there should be high index of suspicion when a baby presents with features of dehydration, sepsis-like features. You should always think that, okay, it could be neonatal diabetes, and blood sugar test would be very, very important in babies who present like this. Transient neonatal diabetes is most often caused by 6q24 abnormalities, and although it remits by a few months of age, it may relapse after puberty. So transient is actually a misnomer. One should always watch for relapse. Roughly half of the permanent neonatal diabetes mellitus cases are caused by defects in the ATP sensitive potassium channel, and these are sulfonylurea responsive. Among syndromic causes, Woolcott Rallison is the commonest. Genetic testing should be done in all babies presenting before 6 months of age and in those between 6 to 12 months of age if autoantibodies are negative, in order to guide the management and prognosis. Maintain the follow-up of all babies with neonatal diabetes. In permanent neonatal diabetes, this is to ensure that euglycemia is maintained. And even in sulfonylurea responsive, sometimes these families tend to think that, okay, now everything is fine. We don't need to follow up with the doctor, but it is important for us to maintain their follow-up to watch for neurological symptoms. And in transient neonatal diabetes, we need to follow up to watch for relapse. Okay, so I'll end here. Thank you. Thank you for a patient hearing.